As part of the research team, it's my absolute pleasure to introduce today's presentation, which asks, is the current approach to H. pylori testing and treatment equitable? This research was funded by the Healthier Lives National Science Challenge. So this is a University of Otago-based research team, which was ably led by Dr. Andrea Teng, who will be leading the presentation today. I must say, this research is entirely Andrea's fault. She conceived of the research idea and really led she's shaking her head, led all of the aspects of the research, but she was ably supported by a team which consisted of Erin Hildred, who was a master's student, Professor James Stanley, who you'll all know is a biostats extraordinaire, and I can see James online, looking forward to lots of your biostats questions. Associate Professor Dr. Stephen Innes, who's a gastroenterologist and clinical specialist, who may also join, be able to answer some of the clinical questions. And myself, I provided very little, but I did try and contribute some Māori health expertise and humour to the research team. So without further ado, I'm going to hand over to Andrea, and I am unfortunately going to have to excuse myself from the presentation within the first sort of 10 minutes. So good luck, Andrea.
Kia ora, thank you, Mel, and so good to see you all here today. So kia ora koutou katoa, ko wahaupai, te whenua tupu, and ko pona ki te kāinga, te Andrea Teng, taku ingoa, tēnā koutou. I'm so pleased to be able to present this work, and I'm particularly looking forward to the questions and the comments that hopefully we have some time for towards the end. So briefly, I'm just going to introduce H. pylori, which many of you are clearly familiar with already, and then I'm going to talk about the study that we've done and why we've done it and what we've found, and then what some of the next steps. So to the basics, H. pylori is a bacteria that can live in the stomach for a long time. It's usually acquired in childhood, either through oral or fecal routes, and it's commonly acquired in families and passed down. People generally don't know they have it unless, so it can cause chronic inflammation, it can cause dyspepsia, it can cause peptic ulcers, and it can also cause some stomach cancer in some people later in life. But the good news about H. pylori is that it's fully it's treatable. I'm going to talk, this is a population-based H. pylori screen and treat strategy that's been recommended by WHO for high-risk populations. So let's talk a little bit about the strategy. There's a population screening program where basically, for background, this is a program that people are tested for H. pylori, asymptomatic people, and then they're treated with H. pylori that's there, basically. In a recent meta-analysis by Ford, in 22, there was half the rates of stomach cancer and a third fewer deaths from stomach cancer and longer term follow-up of some of these trials of a test and treat or screen and treat approach. So particularly effective strategy at reducing stomach cancer, and particularly potential for New Zealand. And so we wanted to, the study's designed in a way to inform this kind of approach in New Zealand as well, or at least give the background, what's already happening. Anyway, I'll get to the study. This kind of screen and treat approach is a high priority in the New Zealand Cancer Action Plan. Te Aho Te Kaho has published that. It's also part of the health equity team at Te Whatu Ora looking into this approach as well, and there's some work that's starting off in this area, which is exciting. So that's the sort of background on how we can prevent stomach cancer. And then now thinking a little bit about New Zealand and what's our current rates of H. pylori and stomach cancer, and what's the context we have here. So in New Zealand, we've actually got very little data on seroprevalence in asymptomatic people. So this is basically a study pulling together the data that's pre-2000 on seroprevalence rates in New Zealand, and it's showing quite a trend in younger birth cohorts that there's lower prevalence of H. pylori. But also here we can see a very strong difference between Pacific in the purple, which is roughly 3 times higher seroprevalence than European, and Māori having roughly double the seroprevalence of European. So it's clear there's a very stark ethnic differences in H. pylori in New Zealand. And when we look at stomach cancer, we see the same pattern here for Māori and Pacific. So, and it's the same thing too, when we look at peptic ulcers in New Zealand, we see 4 times greater rates of peptic ulcer hospitalizations in Māori and Pacific than in European, South European. So going back to stomach cancer, this graph, it's a little bit old now, it's this New Zealand census mortality study, but it shows that over time, those disparities in gastric cancer have remained. So in the yellow and the green is Māori and Pacific stomach cancer rates. And so they're roughly up to 4 to 6 times greater stomach cancer incidence Māori and Pacific than European. So it's one of the most unequal causes of cancer in New Zealand, and it's a large contributor to the life expectancy gap. And we know stomach cancer in the lower part of the stomach, 9 out of 10 cases are attributable to H. pylori, caused by H. pylori infection. And certainly when we did a little bit of modelling in New Zealand, we found that H. pylori was the major driver of stomach cancer inequities in New Zealand, between Māori and Pacific and compared to European. So what do we do in current practice? Many of you will know more than me on the current practice of H. pylori and who is treated, etc. But when I looked at the pathways and the guidelines for H. pylori, they're all pretty similar in that obviously we treat people with a triple therapy as the first line treatment for H. pylori, and that's a proton pump inhibitor such as omeprazole, along with 2 different antibiotics such as amoxicillin and clarithromycin. Is increasing concern about clarithromycin, but we can come back to that being increasing resistance rates worldwide. So keeping that in mind. But yeah, so guidelines for the GPs often suggest offering tests for H. pylori if there's dyspepsia, and proton pump inhibitors don't fix it. And there's also a high risk of H. pylori infection. For example, if you're living in the northern region of New Zealand, or someone is Māori, Pacific or Asian, or born in a country with high rates, or they have a family history of stomach cancer. So the aims of this study are largely, does the current testing and treatment of H. pylori in New Zealand, does that align with our national guidelines? And does that reflect the excess burden of Māori, Pacific and Asian that we're already aware of? And so why do we want to do this? We wanted to improve, or see if there's any ways of improving current management of H. pylori. Wanted to inform this population test and treat approach, like what is that background rate of testing and treating H. pylori already, and wanted to give an example of possible inequities, not just in New Zealand, but in other countries which also have quite stark differences between high risk populations for stomach cancer. So the objectives of the study were to look at the current H. pylori testing and treatment. Is it equitable? And basically we looked at each of these 4 questions by ethnicity. So who is tested for H. pylori? If they're tested, who tests positive? If someone is positive for H. pylori, who is treated? And if they are positive, who is retested for H. pylori? So we started off with trying to identify a study population. And we use the health survey user population, which has its own limitations. So we had this data provided by the Ministry of Health, and we focused in on the northern region of New Zealand. So that's the previous 4 northern DHBs, the 4 regions in the northern area. So the health survey user population gave us age, sex, ethnicity for each of the individuals living in that region for 4 different years, from 2015 to 2018. Now, some of the limitations is that it doesn't have a full coverage of the New Zealand population, and so we need to be aware of that, and it also undercounts Māori, which we'll talk to a little bit as we go through. But it was the best denomination we could find and was useful for this work. So then with the health survey user population, we had, hopefully you can see this arrow, that was linked, well, that was provided to us by Ministry of Health, also linked with pharmaceutical data on dispensing in New Zealand. So we had those national data sets provided over to our study team at University of Otago, and which come with an encrypted NHI. How do we then link test safe data? So we wanted to link in some laboratory data from the northern region from test safe, but they could provide us that data, but they couldn't provide us NHI. So This 3-step kind of process was created. Thank you, June Nickerson, for explaining this to me and helping me put this in place. But basically, TestSafe create a user ID for each of the individuals in their data set, and provided the NHI and the UID from TestSafe to the Ministry of Health without providing any laboratory data. Ministry of Health took that UID and linked it to our encrypted NHI and passed that back to us, so that basically when TestSafe gave us the lab data with the UID on it, we could then link the Ministry of Health data. And happy to explain that if anyone is interested in the data linkage process, but I just wanted to highlight that too, being on the VHIN webinar as we are talking about linked data. So using TestSafe data, for anyone who's interested in this, I just wanted to make a few points and also happy to follow up. But basically it's an application process to access TestSafe data. The application is assessed, and then if you have ethics and approval, then you can arrange for an extract of that TestSafe data. We worked with Health Alliance to do that extract, and then created a high confidential, basically data transfer. The challenges for using this particular data set that I found in the process was there's a limited data dictionary, so there's a bit of clarification, understanding the fields in the data set at TestSafe. There's several samples and example extracts were required to make sure that we had the right tests, and we had all the results linked onto those relevant H. pylori tests. One of the challenges was just the capacity of Health Alliance doing this work. So it took a lot of time, but this was over COVID period and my own maternity leave, so it took us over 1.5 years, but we got there. And one of the other challenges is cleaning the data, because there wasn't consistent test names or consistent results, so they had to be drawn on from different fields and different because they're all basically coming from different laboratory supplies as well, so there's a lot of inconsistency and cleaning required to address that. But basically this is what would be a lot easier if something like TestSafe primary care data was already integrated within health data, which we would advocate for. Now, on this figure, I just want to highlight how complicated it can be linking the data sets, and often journals with quality guidelines, they ask for a flow diagram to report your linkage process, which is easier said than done, but is a really useful process in creating that flow diagram to make sure that you have got the correct links in place. So, for example, in this study, we found that in all steps of our linkage process between the HSU and the lab and the farms data, there was a few percent missing because the HSU itself didn't have a DHB, basically identified for about 3% of the national population. So there's definitely a proportion even within the HSU that we couldn't link through. Another thing we found is that 15% of the positive stool tests couldn't be linked to a treatment, and there might be a whole lot of different reasons for that, whether someone's treated privately or bulk funded treatment. And we can come back to some of that, but just to show that the flow, the linkage process itself, and trying to understand it can be tricky. So just a quick overview of our analysis. This is a retrospective cohort study design from following people with tests between 2015 and 2018. We identified what we actually included, so the whole population, so between 2015 and 2018 from that northern region. And we identified an individual's first recorded test, so any new test for H. pylori rates. Then we looked at those testing, positivity, treatment rates, and they're all presented as crude rates and standardized for age, sex, and year. Regression analyses compared the ethnic differences in rates, also adjusting for age, sex, and year. And we cited different models for each of the testing outcomes, which we'll come to. So overall summary of results, a bit of a spoiler. You might expect the ethnic inequalities, yes, they're present across the clinical pathway, and significant differences as well. So that's right from who gets tested, which is whether, for example, who's turning up at primary care, who is treated, who is retested and retreated as well, and then who was positive, what proportion of each ethnic group were positive for H. pylori. We're going into each of those a little bit further when we looked at testing rates for H. pylori. So every year, about 1.3% of the population had a new were newly tested for H. pylori. Most testing was done by serology, so 6.8 per 1,000 person years there was of serology tests. Stool antigen was done 4.4 times per 1,000. Slightly lower, which was surprising to us, given that's the test of active infection. Stool antigen is usually used to diagnose H. pylori. On this figure, we can see that the ethnic differences basically. So Māori and Pacific on the left having overall much lower, lower testing rates, just less than European, but Asian and MELAA having the highest testing rates here. And you can see that that seems to be consistent across testing types as well. Grey is still antigen and yellow is serology, while the blue on top is the rapid urease test, which is done in gastroscopy, so secondary care. So overall, when we looked at this, Māori had they had almost 1/3 the likelihood of being tested compared to 1/3 less the likelihood of being tested compared to South European, while Pacific had 20% less likelihood of being tested compared to South European. Well, Asian and MELAA roughly double the rates, double the likelihood of being tested. And yeah, I guess we know that there is differences in access to primary care for Māori and Pacific that might be driving this, and there might be other things. I'm interested in your thoughts on that as well. I think one of the other things that was interesting, it's not shown here, but that the testing rates between 16 and 17, there was a big increase in the number of, that's the next slide, but the positivity rates increased over time. So yeah, talking about positivity rates, there was a 21.5% positivity rate overall over the whole population. The highest positivity rates were in MELAA and Pacific peoples, almost 40% positive tests, and that was followed by Asian and Māori, 26 and 23% positivity, and South European down at 13% positivity. So that's shown in this figure here, and we can see that each of the different colors represents a different test. So stool antigen, serology, and then stool antigen, serology, and then rapid urease test. And across those test types, this pattern largely stood the same. There was much higher positivity in MELAA and Pacific, and then Asian Māori. Okay, so all those differences were significant. It was interesting too, positivity rate was slightly higher in males. It was lower in under 25-year-olds, and yeah, increased over time. So this largely, I guess, reflects the background H. pylori epidemiology, but it's possibly influenced too by the testing rates and who exactly is being tested and why. Well, these results here too are all standardized for age, sex, and year. So moving on now to think about the treatment rates. So those that were positive for H. pylori, who was treated. So we followed up for 6 months after the positive test to see what proportion of the age group was tested. So basically the treatment rates were similar, statistically for Asian, MELAA, and Māori compared to South European. But for Pacific, there was a significantly lower rate of treatment, so 10% less treatment for Pacific people over that 6 months. And there's a few things that can be influencing our treatment results, so we don't know exactly what this means, but it does suggest, it seems like there's a quality issue, but there's also possibly a difference in the influence of bulk funded dispensed medicines, which are not included here. It's also private treatments also not included here either. So that's treatment rates, and then looking at retesting now. So this is for everyone that had a positive stool antigen after a everyone who had a repeat stool antigen test after a positive stool antigen test. So everyone got a positive stool result, how many went on to get another test within the 12 months following. And so compared to Sole European, Māori and Pacific were is half as likely to be retested. And so you can see these findings on the left side of the table here. Māori and Pacific significantly less likely to be retested than Sole European, but also Asian being a little bit more likely to be retested at the same time. So this includes people that are being routinely retested at 4 to 6 weeks after they've been treated. It's also including people that are being tested for other reasons, perhaps they're representing with symptoms to primary care. And I've also put on here, we can see that which ones of those tests are positive, so what proportion are positive, and there was no statistical difference in the rates of positivity between by ethnicity. So in summary of that whirlwind tour of these findings, compared to Sole European, we can see here Māori and Pacific the lowest rates of testing, despite the guidelines highlighting Māori and Pacific for having a lower threshold to test. They had the lowest rates, and positivity rates were highest in MELAA and Pacific, followed by Asian and Māori. Treatment rates were significantly lower in Pacific people. Māori and Pacific were half as likely to be retested. So overall, showing a picture of an underservice really of the Māori and Pacific population in New Zealand, and also sort of possibly highlighting that disconnect between the guidelines saying have a low threshold for these groups, and actually these groups being the ones that have the most barriers to accessing primary care around New Zealand. So as compared to the Māori and Pacific groups, what we see for Asian is perhaps closer to where we would like to be. Asian also had these high positivity rates, but they were the most likely to be tested, so twice as likely as Sole European. They were more likely to be treated slightly, and not significantly, and retested, so they were 1.36 times likely as Sole European to be retested. So how do these findings compare to what's seen elsewhere, what we already know? Well, gratefully, we have a study from Kubovi, recently published in New Zealand from Canterbury over a similar time period. And interestingly, they also found lower numbers of tests in Māori and Pacific compared to European when they compared their test numbers versus the census population. So they found the same ethnic pattern and positivity rates, reflecting similar disparities by ethnicity across the country. But what they also found is lower positivity rates than our study, including by ethnicity. So they had their stool antigen was positive 10% of the time compared to 26% in the northern region in our study. And that's consistent with what we know about a geographical gradient between the north and the south of New Zealand. So what are the strengths and limitations of this analysis? Well, we believe so. The 7,000 person years is obviously quite useful to have those numbers to compare these differences, and that's in the denominator population. So the inclusion of primary and secondary care lab data was also useful, though to note we didn't have gastric biopsy histology in this analysis or any private funded testing. We were able to link to population and farms dispensing data, which to give that whole picture across the pathway is really useful. Some of the limitations, the HSU being incomplete, encourage undercounting Māori, makes our ethnic comparisons conservative for Māori. So they could be worse than what we're seeing here. We could not include any bulk funded medications and those that are not funded. So those are not included in our treatment. And also we're assuming that people get all of their testing and retesting both in the same region and both by the public funder system in this analysis. So recommendations for addressing inequities for Māori and Pacific, well, improved clinical guidelines appear to be important, but not just the guidelines, the application of those guidelines. So the first thing here would be internationally, it's recommended that with routine retesting for H. pylori at 4 to 6 weeks after someone's completed their triple therapy or their treatment for H. pylori to ensure that that has been eradicated. And that's not something that it's done some parts of by some clinicians, but it isn't simply widespread in our data. And we would recommend that go in those clinical guidelines. And I believe that, we're actually supporting Te Whatu Ora to write a paper, which has been led by the health equity team at Te Whatu Ora, that hopefully will help, that will address this. Still, and that this paper can support. So still antigen is recommended still for diagnosis rather than serology. So I don't know why we're using so much serology, but that's an important part of the guidelines and testing for H. pylori. Certainly from our data, it didn't look like serology was being used as a diagnostic test or as a very not very commonly as a diagnostic test, and it wasn't always commonly being followed up with a stool antigen either when it was positive. So it was a bit unclear, why it was being used so much serology. Further work's needed on antibiotic resistance and treatment effectiveness to ensure that we have got effective first-line therapy. And those retesting data will support and help that. Equity, so number 2, and I think our major recommendation from this work is that an H. pylori screen and treat approach in New Zealand is needed for asymptomatic people with a high risk of stomach cancer, such as has been identified in Māori and Pacific. So that can help address, like we're focusing on Māori and Pacific in a screen and treat approach that's going to help address a whole lot of those inequities that are here when these groups are not being tested still being tested at low rates compared to everyone else. So just wanted to highlight this paper led by Cam Shaw and Stephen Inns, looking at some of the barriers to gastric cancer prevention in New Zealand. And we look at some of these questions about what's needed for a pilot, and actually some of the questions that a pilot study of H. pylori screen and treat in New Zealand can answer, which is an important next step forward. And something that we're looking at Te Whatu Ora hopefully can progress in the short term, we're hoping. So current research, I just want to highlight a study that's currently ongoing, led by James Stanley and myself, as a prevalence study to understand H. pylori in New Zealand, which we also can help support this work around screening and treatment of H. pylori. And this prevalence study will help answer some of those questions too. And in just closing, I just want to make a couple of comments about using the linked laboratory data as an example of primary care data. And obviously linked laboratory data is really useful in examining those links between testing and treatment and the whole pathway from primary care through to secondary care. And this is an example of that, of the value of linking primary care to the wider health system data. Primary care data is a key gap in our current health integrated data system in New Zealand that's been clearly identified. And the process of aggregating primary care, pulling it together from patient management systems, and also aggregating laboratory data from around the country has been on the Ministry of Health work program. They have been working on that until very recently, when this has been completely stopped and deprioritised. I just want to highlight this is an area of future work we need and could provide huge value to understanding not just this little part of H. pylori, but the primary care data is huge use to a lot of studies. I want to acknowledge, again, funding from Healthier Lives National Science Challenge, Health Alliance for providing the data for this work, the data extract, June for her support, and Te Whatu Ora for their use of the health data too. So I'm very interested in your questions. So first comment that Karen mentioned, that's near the start, TestSafe data access process is changing. It's likely to be, so the process I use is not up to date. This is a good point. It's likely to be the National Data Governance Group, still an application and assessment process.
I'm Kristen Bernstone from the Gut Cancer Foundation. I just wanted to introduce myself and say thank you very much for the webinar. We've been doing some public outreach stuff around H. pylori and the links to stomach cancer. during Stomach Cancer Awareness Month in August. So yeah, if there's any way that we can help with outreach and awareness, we're very, very happy to do so.
Perfect, thank you. And I'm sure we can find your contacts online, but
Yeah.
we'll track you down. But yeah, no,
Yeah.
that's super useful, Kristen, and so good to hear about that too, because it's we need to be connected. That will be really useful. Thank you.
Hi, Andrea. It's Cam Shower here. It's fantastic presentation and really inspirational work. And I think this is the sort of large volume data that we need to sort of really move some mountains forward. Well, you mentioned about serology. Why do you think so many people are using serology? Because the guidelines, Auckland, in BPAC and say don't use serology. And was there some worries about some false positives for acute infection with serology?
Yeah, really good questions. I think, I've thought a lot about the serology, and I love other people's input as well. I wonder if it's being it's possibly in some cases used as a sort of a screening test, and then maybe followed up by a stool antigen. Maybe it's being used for a variety of things. I guess that's one of the possible things. Maybe the blood test is easier to access than the stool antigen test for some people, more preferable. I guess it's also possible it's just being added on to the bloods. It's just being you're in hospital or whatever, you're somewhere and the GP adds it on when it's sort of another sort of screening approach, I guess, as well. I don't know. But and then previously I know that there was guidelines recommending using serology in high-risk groups as a diagnostic test. By the time of our study, I think those guidelines had changed, but it's possible that there was still some previous guideline informed practice going on and using serology as a test. But yeah, you're right. Like if you're using that as a diagnostic test, did you talk about false positives? Yeah, there is a chance of false positive.
Yeah.
Did you want to say anything about that, Kim?
Oh no, I was just worried that might be the case, in chronic infection, especially in Asian patients.
Yeah. Yeah, I don't know. Yeah, like if they've been treated already, isn't it? And they're still showing positive serology, that's definitely a chance. So thanks, Lily, for your comment. You said you have to type the indication in your lab request. So that's interesting. I didn't see that information in the lab data, but that might be in there somewhere to look at. The indication for the lab test. That's really interesting. I might follow that one up.
That's just in Southland because we have low incidence. So
okay.
I know when I was in Auckland, there was no restriction, but I was like, so I think it probably regionally there are different, so that might be a deterrent to some people ordering it.
Yep.
So we can't do blood test at all, which is fine, but to me it is a barrier in terms of acceptability of the test. So when I was practicing Māngere, I was more likely to order a blood test because I could just do it right there in clinic and the patient wasn't going to get all icky about it. Whereas trying to encourage somebody to, talk them through a stool test and actually get it done is a lot more effort. So that's why I would have preferentially done the blood test in Auckland, but in Southland I can't actually order it at all.
Yeah, that's really useful.
So the lab obviously has ability to be able to control that.
Yeah. So
but my other point I think is really around the clinicians' education and knowledge around the marginalisation data for Māori and Pacifica, that we have the power, we have access to that test and we have to think of it and actually do the right thing by ordering it. I think to me, like it would be really interesting to know presentation rates for the symptoms that should activate a test that aren't actually happening.
Yeah.
Because is it Māori not coming or is it actually Māori not being offered? Which, it's probably a combination, but I think the Māori not offered is a really important step that we can influence.
Yeah, definitely. I think that's a really important place, in the process of updating or whatever happens, the guidelines. Yeah, that's really important that we're thinking about education. I know Karen's mentioned that. Karen Lockall on you too. And getting, if once we're clear exactly what we're asking people to do, they know and are completely aware of this. I don't know what that level is either or how much of a contribution that is. But that's interesting, Lily, when you're talking about doing the serology, because it's easier to know you're going to get it done, is slightly more acceptable. I'm wondering, does that then do you use it as a screening test, or do you and then go on to use a stool antigen, or sometimes use as a diagnosis and then treat?
I can't use it now because of where I live, but I used to use it for people that had symptoms of concern that hadn't previously had a positive test. So if they previously had a test, obviously I'd go straight to stool.
Yep.
But this was a predominantly Māori and Pacific population.
Yeah.
So in Māngere. So it was a high-risk population. So if they came back positive in serology, then I was treating based on serology. And then probably doing the stool, or then I do the stool antigen as the follow-up.
Yeah. Cool. Thank you.
But in Dunedin, you can't do that. So it's a way of manipulating what people do, I guess, is what I'm saying.
Yeah, so that's going to affect regional differences and approaches as well. Yep. Okay, where shall I go? Karen's comment there was, yes, wondered if the test acceptability is likely to be part of it. And we don't have a world view of what, we have a view of what antigens are ordered and not completed as well. Yeah, exactly. So we're only reporting completed tests here. And it might be that a whole lot more are ordered and are not seen if they're not returned. Going back as well, Nina's comment here is, I think that back in, Nina Bevan, thank you. I think that back in 2015, serology may have been on the guidelines. Yeah, that's exactly it. And that the recommendations have changed over time. So serology was used as a diagnostic test in 2015. Yeah, I mean, I think even the data system, if there were primary care data, you could even look at some of these things too, about what's being ordered, indications, etc.
Andrea, Cam Shao here again. I just wonder, like, I don't know if there's data to hand. I don't have it off the top of my head in terms of access of Māori and Pacifica to regular primary care, which you mentioned in your talk as a limitation. But, if you took this to primary care, they may say, well, a lot of these patients aren't presenting to us and therefore we can't necessarily check or review them. Do we have that data for, the same cohort? I guess it's tricky to get. Who are the folks that do have regular access to primary care? Because it's similar data with HCC and Asian patients, also very high risk for hepatitis B and otherwise, but they have better outcomes with just regular medical contact.
Yeah. So I think that there is definitely a lot of different studies have looked at this question in different ways, I think. Ones I can think of is the health survey questions on barriers to accessing primary care. Those are definitely higher in Māori and Pacific groups. So they report more perceived barriers to primary care. And I don't know the specific study. I can look up what else is looked at access and what we cited in this paper, but I think there's definitely pretty clear evidence that Māori and Pacific do have poor access, which will be contributing.
Because you worry it's just going to get worse, especially with financial difficulties now, in primary care and even if you disseminated this information to primary care, it may not necessarily be able to improve the situation if folks aren't presenting. So I guess that really has the impetus for the screen and treat as opposed to sort of emphasizing to GPs.
Yep. Yeah, it's definitely a systemic driver, isn't it? That, social determinants as well as, primary care funding. If we're not going to, reduce the price and we make it accessible for everyone, then those ongoing barriers to primary care will be difficult to. They're probably always going to persist at some level, but how, there's big investment will be required to kind of improve that access. But yeah, in terms of H. pylori, I think that makes it even more important that we are pushing forward with the screen and treat approach because of the other benefits as well, isn't it? So the dyspepsia as well, people presenting with dyspepsia of H. pylori, I think it's something like a 10% level. I mean, correct me if I'm wrong, but there's still going to be 90% of people with H. pylori that are not presenting with a sore tummy to GP. There's no chance of them being tested and treated either. with e-ordering now, it would be, Nina Bevan, thank you. It says that with e-ordering now, it would be possible to look at tests ordered versus completed tests through Aotearoa, I imagine. That's interesting. Yeah, so that's held by Aotearoa possibly. Yeah, that's something to look into. Thank you, Nina. So is it the primary care management system? And Karen Bartholomew, so even with primary care access, acute issues are usually the priority. Yeah, so dyspepsia is probably not a compute compared to other things, and you can imagine the comorbidities that people sometimes, well, even individually that I like to present with to my GP. The more that you have, isn't it? Then it's not always going to be the front of mind thing to sort out. Thanks so much. Appreciate so much your input and questions. So yeah.